So good afternoon and welcome everyone. This is the Center for Environmental and Occupational Health Research. A warm welcome to Tshepo Phakisi, who is an environmental health practitioner and recent MPH graduate from our university. He has a research interest in climate change and human health, and he will be speaking to us on assessing the role of temperature and air pollution in exacerbating childhood asthma incidences in Cape Town, South Africa. A little bit in terms of his background, he currently works as a climate engagement coordinator for Doctors Without Borders, MSF, Southern Africa, within the Operational Support Unit in Joburg, which is where he's based. He, in this role, is responsible for building up institutional knowledge and understanding of the impact of climate change on health in Southern Africa and beyond. He's also has over 5 years of experience in the public sector, where he was an environmental health practitioner in a municipality and hospital setting. So welcome, Tshepo. If you could perhaps just load your presentation.
Thank you very much. I'm loading my presentation right now. Oh, thank you, Prof, and thank you for the invite. And hello and welcome, everyone. I'm saying welcome, but I'm also invited. So, but today I'll be presenting a research on assessing the role of temperature and air pollution in exacerbating childhood asthma. And I'm delighted to have this opportunity to share my MPH research dissertation. So currently I am the climate engagement coordinator, as just mentioned, at MSF South Africa. And so this paper is, or the research was supervised under the Prof. Andrea Rother, Dr. Kirsty Gottsmark, and Prof. Eda Weinman. And I think I can continue. All right. In continuing with the presentation, this is the content of the presentation. We would have the introduction, background, methods, results, discussions, limitations and challenges, implications, and conclusions. So in terms of the introduction, asthma is a chronic, it's a common chronic respiratory disease that is characterized by the inflammation and airway and narrowing of the airways. So it is also the prevalence, phenotype, and severity of asthma in children influenced by the host risk factors, environmental health risks, and climatic weather conditions. And asthma is currently affecting around 339 million point. Sorry about that. So asthma is currently affecting 339.4 million, sorry about that, and that equates to about 4% of the total global population. And in terms of continuing with the introduction, so there's been a rapid increase in the prevalence, severity, and exacerbation of adult and childhood asthma globally, and this is also mostly seen in low and middle income countries. So same as South Africa, where in Cape Town it was estimated that around 20% of the children aged 13 and 14 would have asthma in Cape Town by the ISAC study, phase 3. And in terms of the increase of asthma prevalence appears to be too rapid to only attribute it to your genetic or commonly researched environmental triggers, such as your seasonality, pollen, and air pollution in children, and both children and adults, of course. So, and it is also estimated that about 23% of all deaths globally are attributable to environmental determinants of health. And this is also now looking at also air pollution, the role in which it plays in terms of the respiratory health or respiratory diseases such as asthma, and how it impacts childhood asthma and adults. And this has quite been studied by a lot of studies. Global and regional climate change is a long-term shift that is caused by emissions of greenhouse gases into the atmosphere by natural and anthropogenic sources. And of course, anthropogenic sources account for majority of the emitters. And this basically, these anthropogenic sources, they release greenhouse gases or pollution emissions into the atmosphere by burning of fossil fuel in the process of energy generation, manufacturing, etc. So, and this process really contributes to climate change and also decreases the air quality. So climate change has been it's been classified as the biggest health threat in the 21st century, and because mainly it also affects the social and environmental determinants of health, such as clean drinking water, good air quality, food security, and adequate shelter. So, and the impacts of climate change on childhood asthma prevalence and exacerbations are poorly studied in low and middle income countries. So here the study is taking place in Cape Town, South Africa, one of the most urbanized areas, and it has approximately around 4 million people. And it is also has industries such as your oil refinery and airports as well, harbors. These are some of the emitters of some of the pollutants we'll be talking about today. And so the area is characterized by dry summer conditions, mild winter seasons, and rain occurs mostly in the winter seasons. So in terms of the research gap, why we needed to really observe or really do the study, so the gap exists in the sense that there hasn't been really many of the studies that have looked at asthma and temperature and air pollution, looking at the combined effect of both exposures. Though there has been a lot of research on air pollution and respiratory health, particularly asthma in South Africa, and none really focused on children and temperature with air pollution in place as well. So, and then another thing is South Africa. I mean, we are one of the country that has a lot of air pollution sources, and which is the main contributor to the poor air quality that currently exists, which are also increasing, which play a role in childhood asthma prevalence and incidences. So there was a need to investigate the effect of temperature and air pollution on childhood asthma exacerbation and possible prevalence and incidences in South Africa. So the aim of the study is to determine temperature and whether temperature and air pollution with these variables, air pollution variables, PM 2.5, PM 10, NO2, O3 variables, whether they exacerbate childhood asthma incidences in South Africa. And the study hypothesis is that we hypothesize that temperature and air pollution are associated with hospital treatment of childhood asthma. So in terms of our study objective, we identify, the first objective is to identify specific air pollutants that are associated with asthma cases that are treated at RSH in Cape Town. And the second is to explore the relationship between ambient temperature and air pollutants with cases that are treated at RxH. So in terms of the methodology, we did a time series, and this study was for the period, for the 3-year period, using a snapshot approach. This is due to a lack of quality data because we looked at 2009, 2014, and 2019. We reviewed medical records from the Red Cross hospital and analyzed it with corresponding temperature and air pollution data from the city. So, because Red Cross Hospital is a referral hospital that caters for children under the age of 13, our study participant or group that we chose for the study was from the age of 6 to 13, all genders, and those that held residential addresses in Cape Town. We do know that Cape Town has a lot of tourists, and we would now exclude them from the study. and those that had asthma diagnosis were included into the study. And the reason for the exclusion of the people that didn't have addresses was mainly because we couldn't now associate them or triangulate them according to the monitoring stations that are available in the city. So research ethics and permission was applied for and received from the University of Cape Town Human Research Ethics Committee, and permission was we got permission from the City of Cape Town and Red Cross Hospital as well. So in terms of the data collection, we collected the asthma data from the Red Cross Hospital, and we extracted the data from the clinical system, which included inpatient and outpatient data, and hospital referrals were including Klipfontein Subdistrict, Mitchells Plain, Rosebank, Mowbray, Rodenbosch, and Salt River. But in terms of our data, what we got a variety of basically in terms of people, maybe some staying in Khayelitsha and you name them. So, and we also got temperature data from SOAS, South African Weather Services, which were minimum and maximum temperature. And we also got air quality data from the City of Cape Town, from which include the variables PM 2.5, PM 10, NO2, and O3. So this is our study area. It has all the monitoring station and the hospital highlighted there with a hospital arrow pin drop. So in terms of the statistical analysis, we did demographic, we did a descriptive statistics of getting variables to analyze for gender, age, air quality monitoring station. This is where we were now linking them to possible source of where we could actually measure for air pollutants, and then the type of asthma as well, which we found in the data as recorded according to the ICD code 10s. And we also had seasons of asthma. This we utilized using using the dates in which they were seen at the hospital. And temperature data, we got the minimum and maximum, and we also created two other variables. This was the average temperature and the Daniel temperature. So the Daniel temperature is the variation within the minimum and max temperature. And we also got air quality data, PM 2.5, PM 10, NO2, and O3 from the City of Cape Town. And all of these, in terms of, they were analyzed. And in terms of PM 2.5, we used a 24-hour average. And for PM 10, we used a 24-hour average as well. And for NO2, we used the highest. And whereas for O3, we use the 8-hour average. And so in terms of our analysis, we used a Spearman's correlation coefficient, analyzing to assess the association between daily air quality and temperature variables. And we also used a multivariate regression analysis. This was when we were analyzing for the three variables that we have. And we also used our statistical analysis was performed using the SPSS 27. So in terms of our results, we have our descriptive results. In terms of our health data, we had around 7,753 patient visits for the 3-year period, for those whole 3 years. From 2009, we had a 10% increase to 2014, and then a 5% increase to 2019, respectively. So, and these were all the cases that were treated at Red Cross Children's Hospital. And in terms of the total visit that they had, we had 4,000. Okay, let's use percentages here. We had like 56.8% that were males, and then we had 43.2% that were females. And visit by age group, we had 63% that were from the age of 6 to 9. So we characterized according to that. And we had also 37% 10 to 13 years old. And in terms of the air quality monitoring stations, we had for Athlone, we had 56.4%, and whereas for Khayelitsha, we had 27.8%, City Hall, we had 4.1%, and for all the others remaining, we had 11.8%. So in terms of the diagnostic type as per ICD code 10, for predominantly allergic asthma, we had 53%, and for unspecified asthma, we had 46.4%, and the remaining was for mixed asthma as well. And now we also had the visits. In terms of our data, we got per season. It was relatively the same. It was more of 20. They were sharing basically in terms of looking at this data. We had 26.9% for summer, 25.4% for autumn, 26.9% for winter, and 20.7% for spring. And so now delving deeper into that descriptive statistics, we in terms of the years, we had around 1,053 patient data that we from 2009, and we had 2,701 for 2014. We had 3,099 for 2019, and for in looking at that, our inpatients were roughly the same in terms of the percentages. It was 5%, 5 and 6, and whereas it was roughly the same in terms of percentages. And going to the gender, we also had more males in 2019, 2014, and 2009. And now we also, we also had in terms of our age groups, we had more in terms of the one with the age group of 6 to 9, which were 62% at 2009, 64% at 2014, and then 63%. So it was also fairly consistent in terms of the distribution. And this data, I'm not sure if you can see it clearly. In terms of Athlone had the largest share of the data. And I think this is largely because it is in the catchment area. And followed by Khayelitsha, and then City Hall, and all others sharing the percentages. In terms of now asthma coding, as per ICD code 10, we had, in 2009, we had like predominantly allergic asthma at 36%, whereas it increased over the years to 2014, in 2019, where from asthma unspecified was high in 2009 and decreased over time. And in terms of seasonality, this is fairly consistent across the years as well. And one thing that we can say is that in terms of spring, the numbers are quite, or the percentage is quite low, at 20%, whereas the others are ranging from 25 to 26 and 27. And in classifying these seasons, summer, it's your conventional South African summers, which is December, January, February, autumn being March, April, and May, winter being June, July, August, and spring being September, October, and November. So in terms of the air quality, this is the table which highlights the information that we received from the city. And as the legends below, you can see that the X is for the data we received, but it was not usable because there were no readings or there were too many gaps. And then the dash is that we did not receive the data. And then the green tick is that we received the data and it was usable, although there were gaps, but we managed to use the data and apply some statistical modeling to it as well. So this descriptive statistics for temperature variables. So we have for mean, and we also have for standard deviation IQR as well. So looking at all the years here, one thing that is I think it's consistent is that we see throughout the years in maximum temperature is that the temperature is more likely to fall within from 19 to 25 degrees. And also looking at the minimum temperature, I think those I'll highlight those a lot because these were the original data that we received. The others we created using average and general temperature. And this is for air pollutants. What we have is we have for Kailicha, where we have a mean of 44.6, and meaning now our data would fall between the 28.52 to between and 55.97, and we have for which I mean, again, looking at this data as well, there's a lot of variability in the data. And now moving on to the frequency of asthma exacerbation per monitoring station when we look at classified according to gender and the type of information that we received in terms of like outpatients. So Athlon, let's focus on this red blocks. We have Athlon and Kailicha. I highlighted those because that's where most of our data come from in terms of the health data. And what we can see is that males, we have more males in the outpatients than females, and it's consistent across the board for all the years. We would have, I mean, 54.5% in 2019, whereas for 2014 we had 53.5, and then for 2019 we have 61.1. And this is, I think, and the one difference is just that on the on this, it's giving. We also have, in terms of Kailicha here, we had 31.6, and we also had for females we had 31 that were seen. So basically all of them, the percentage that they're adding on to is the one written on the total. So yeah, basically both of these location taking the lion's share of the data, and some for obvious reasons. And for inpatients, what was different was that we now had more females being admitted for asthma exacerbations than males. But the percentage was quite low. It was not a big difference. And now moving on to by in terms of age group. See, there's a mistake here, but it's by age group here. So in terms of the outpatients, we had about we had the 51% on athlon for 2009, and we also had for 2014, we had 49 for the age group of 6 to 9 as well. And here we also had 67.7. And now, I think the most important thing that we are highlighting here is that the data that we are receiving from both these stations really had more of a say in terms of our study, and whether be it some limitations or not. Yeah, and this is for inpatient as well. And inpatient, there's really not much of a difference as well in terms of the admissions. We still have variation in terms of, now looking at Khayelitsha, we had 31%, and we had for 2014 we had 24%, and then for 2019 we had 18.2%. And this is really, there's not much of a difference to talk about here in terms of the data. So using SPM's correlation coefficient, we did for table view, and this is one of our main results, where we found that maximum temperature is highly correlated with PM 2.5, and we have diurnal temperature as well, positively correlated with PM 2.5. And what is quite consistent is we find both maximum and diurnal temperature being correlated to also PM10, PM and diurnal temperature as well, meaning the temperature variation. So this is a similar result, but we looked for Khayelitsha. This was where we also got the data from, where diurnal temperature is also strongly positively correlated with PM10. And we have in maximum temperature also correlated with PM10. The one difference that we have here, we do have a correlation with average temperature for PM10 in Khayelitsha. So using the multivariate analysis, we looked for also seasonality, where now when looking at these 4 seasons, comparing these 3 to the summer, we had autumn being at a significant level of 0.01, and less than 0.01, and this one also for winter less than 0.01, same as for spring. And what we see that it is consistent here in Khayelitsha, and we also observe that in terms of table view. We see the same results basically, and this really indicates the relative risk for the relative risk for getting for being treated with or treated at the hospital with asthma during autumn is 1.52 higher than in summer. Same as for winter, for spring in 2009 for Khayelitsha. And moving on, we also have PM in terms of the air pollutants. We're looking at PM 2.5, and one most, although not significant but quite important results that we are getting is that we have PM NO2 that we have NO2, which has a relative risk of 1.01, but not significant. It's also not significant, and we also have for O3. Also not significant. The other one that is important is the PM10 for table view as well, but though also not significant in terms of the statistics. The one issue that we had was for table view was for PM2.5, which we'll explain a bit in our limitations or challenges that we faced in the study. And in terms of the diurnal temperature, it's also statistically significant at 0.05, where we have 1.02, and then this is, and we also have another one in terms of a significant number, 0.97, being from City Hall, at less than 0.01. Now, in terms of the results, right? So there was a statistical significant association observed in terms of childhood asthma exacerbation and seasonality. So this is what basically the results that we saw for Kailicha and for let me just go back for Kailicha and for table view, the results were consistent with that. And we also have that diurnal temperature is an important predictor for it's strongly associated with PM2.5 and PM10. And also this study found significant association between childhood asthma exacerbation, diurnal temperature, and maximum and average. And then there was no significant association that existed between asthma exacerbation and air pollutants. So in terms of our study, right, our analysis indicate that asthma exacerbations occurs more in South African autumn, winter, and spring seasons as compared to the summer. These results were observed in another study that was done in the US, where 3 states data were collected from 3 states. And what we saw was that asthma exacerbation would peak in the winter, autumn, and spring season as compared to the summer, where it was its lowest. And also the study conducted in Australia also found a statistical significant relationship between diurnal temperature at 10 degrees Celsius and asthma and childhood asthma exacerbations. The other one is that what we found in terms of our study and what is out there in literature is that there was a high, the one study found that a high diurnal temperature was significantly associated with hospital admissions for childhood asthma. And this increased from 6.7 degrees Celsius to 16.8 degrees Celsius. That resulted in 13% increase in hospital admissions for asthma. And when stratified by mean temperature level, every 1 degrees increase of diurnal temperature at a low temperature, that was associated with an increased hospitalization, a significant increased asthma hospitalization for children, in terms of total children being at 5%, girls being at 3.7%, and boys being at 2.9%, and school children in total being at 5% as well. And also a systematic and meta-analysis study on asthma emergency department visits increased at PM 2.5 concentrations. So this is really what is different with our study. Our study found something that does not exist there. And this, which we'll be addressing later on in the limitations. And now, we also, again, we found that children are more susceptible to PM 2.5. And we also, this was also supported by an Indiana study that found a significant positive association between ambient pollutants and asthma emergency department visits during warm seasons for people aged 5 to 44. So, and now looking at O3, what we found was that daily concentrations or increases in daily concentrations of O3 with the same with the same day or 2-day legged or 3-day moving average were associated with increased risk of as emergency department visits of 3.2 at a confidence interval of 95% and for same day it's at 3.2%. For 2-day it's 4.4%, and then for 3-day moving average it's at 4.8%. So challenges and limitations. So most of the air quality monitoring stations had no data or insufficient data for analysis. And most health data, meaning 56.6%, were from Athlon and had none to limited use, really, due to the fact that we could not utilize it because there were no data to assess it too. And we also, in terms of the health data, we did not receive information on secondhand smoking. And this is very important because secondhand smoking accounts for about 40% of about 40% of children are exposed to secondhand smoking in low and middle income countries. And again, lack of data categorization. So the problem was now you were having this health data, but it was not clear whether in terms of the outpatients, whether it was a visit, it was due to an emergency or due to an appointment system. So that created that bit of a problem to really understand and pinpoint to say, now this is exacerbating asthma attacks. And then we also now, there's also a disregard in terms of the environmental exposures from the residential areas and home environment. So I think an improvement could be when when these studies are done, consideration be taken into whether there is paraffin cooking and other source of indoor air pollutions. And also, now moving on in terms of implications. So the health departments must be aware of the risks posed by diurnal temperature on child health, and early warning systems should be implemented to predict temperature spikes for preventative actions. And also, so as climate change also increases or continues, diurnal temperature is likely to increase. And we saw that by every increasing degrees, we get an increasing number of asthma exacerbations. So, and our findings also illustrate the need for child respiratory health to be addressed at all levels, and more data is needed to further study and really gain more knowledge in terms of how air pollution, temperature, and other meteorological variables play a role in asthma exacerbation. And there's also a need for long-term data. This is very important, long-term data and to ensure that it's available and something that I think I went onto the system a few weeks ago, and the new system for air quality still, but you could now still see there are still gaps happening in that. Again, our study highlights the need to ensure that we include health as a priority in terms of meeting the goals of the Paris Agreement. And in conclusion, our study found a significant association between childhood asthma exacerbation and temperature, and no significant association existed between childhood asthma exacerbation and air pollutants. And there was a significant association between childhood asthma and exacerbation and seasonality, and general temperature is an important predictor for PM 2.5 and PM 10. All right, thank you very much.
Thank you very much, Tshepo. The floor is now open for questions. You can put up your hand, those of you who have a question. Go ahead. I see somebody's hand up. I can't see who it is.
Shahida,
yes, go
it's
ahead,
me,
Mohammed.
I think, unless there's someone else as well.
Go ahead. There is someone else as well, but you can go ahead.
Oh, okay. Well done. This was a very nice presentation, Tshepo. And I think you've done an interesting corpus of work. Just some reflections and observations, since we've been doing many studies on childhood asthma and air pollution. Is the one issue that you have not addressed adequately are exposures to allergens, both in the indoor environment and in the outdoor. And these play an important role in asthma. As you rightly point out, that 50% of your cases were of allergic asthma, and the other was presumably non-allergic asthma, which fits well in line with other studies. So, so my question to you is that did you factor in exposures to pollen, to animal allergens? I know you spoke about environmental tobacco smoke. Did you also factor in issues of mold exposure? So that was my one question to you. And the other question is your PM 2.5 and its relationship to asthma exacerbations. Because there was a high correlation with temperature, do you know which one is mediating which factor is mediating the other? It may well be that your variations in your temperature may be related to variations in your PM 2.5 in relation to that. So I'll leave it at that. And yeah, thank you so much.
Tshepo, would you like to respond?
Okay, thank you, Prof, for that question. And in terms of the factoring in other forms of factors that could exacerbate asthma, such as your pollen or allergens, we did not take that into consideration. Again, it was mainly because this was a study that really looked at secondary data collection from the hospital and the city of Cape Town. I think it's quite important to include such information so that one can have a holistic approach into getting what really exacerbates asthma and looking at those aspects. Say what is important as well is, I mean, tobacco smoke or secondhand smoking, that is also not accounted for, because we thought we could get that data from the from the health records, but unfortunately we couldn't, and it made it a bit difficult to really tease out who has someone who smokes in the house. And I think from that point I think there are elements in which we could improve on to have all the information together. And I know that initially I had thought of doing also including allergens, and it just at this time it was not incorporated, but it is very an important observation in terms of that. And in terms of your second question, in terms of what in terms of which one is really modifying the other, or mediate effect modifier per se, right, Prof?
It's just more whether, it's not necessarily effect modifier, but more which is really mediating it. Is it the change in the temperature, or is it the change in the PM 2.5? And the reason that I ask is because they seem, according to your data, they were highly correlated, if I'm not mistaken. So maybe you want to run a model that just has one of them in and see whether each one individually, and see whether you come up with the same answer, and that may help you. And the other I noticed also is you are presenting effect estimates per sort of location. I wonder whether you will get more power, and maybe you've already done this, where you've combined all the data in one data set, and just add a variable which is for location. You may end up with stronger power to actually show something. So that is another suggestion for you.
Right. Okay, thank you, Prof. In terms of adding all the data together, that was one of the things that we thought of doing, but what we saw was that okay, I think what is important, and what we wanted to reflect was really there is more need for us to have more data that is representative of actually what the person gets to breathe in, or the child gets to breathe in. And I know it's not a perfect model that we used, but it is unlike when we use maybe having personal monitors, which would really give a very, very comprehensive and a beautiful set of data. But it would have, in adding the data together, it was one of the thoughts that we could have went into. And we saw many studies have done so. I mean, there was a study that was done in Cape Town as well that was looking at adults, and they combined the air quality data from across stations and used the assumption that air pollution, everyone is experiencing the same type of air pollutant, or they're breathing the same type of air quality. But in terms of running these models, I think I will definitely look into it and see if there's a difference in the analysis.
Thank you. There's another question about the static monitors and attributing the air quality by residential address. Do you want to pose your question, please?
Yes, hi. Thank you, Tshepo. That was a very interesting presentation. I'm Monica. I work at the University of Victoria, and I do air quality research and climate change research. So I was wondering, I've had some problems with accessing static reference monitor data from the city of Cape Town, because sometimes the monitors go off or they're not powered, and then you lose that data. So what I've been trying to do is using low-cost sensors and wearable sensors. The reason I'm asking is because, like with your study population, most of these children spend time at school. So the exposures at school would not necessarily be the same as the residential address monitor that you assign them to. I just wondered if you maybe thought of incorporating low-cost sensors, maybe in the next phase of the study, because there are some monitors that are being developed by UN Habitat or Purple Air, etc., which would provide you with like timely average air quality index data. So that was my observation. Thank you.
Oh, thank you very much, Monica. Thank you a lot. And I think this is one of the things that when we thought of if this would proceed further, it would be something that we need to look into and I see Prof's hand is on.
Andrea, go ahead. Andrea?
Sorry, mine is not in response to this, Tshepo. Mine, I make a comment when you're finished. Thank you.
All right, Prof. So yes, so I think that is a very valuable comment, and I think going forward, really we need to develop or have these low-cost monitoring or sensors to be installed in or I mean installed in various locations like schools and all that. And again, we also use the assumption that in terms of children will be staying in areas such as, let's say, for example, Khayelitsha would be more likely to be attending schools in Khayelitsha as well. So it was mainly assumptions as well in that point.
Andrea, would you like to pose your question or comment now?
Yes, thank you. And thanks, Tshepo. Well done on presenting what was very complicated research and data to collect. I see we're running out of time, and I just really wanted to say that, it's so important when our MPH students do quite ambitious studies like this and really highlight the complexity of data. I mean, I think, you've emphasized it time and time again that the access to data is very problematic. And then how does one move forward in terms of trying to either look at associations or prevent any health impacts? So I'm hoping that the findings, once you've published it, the findings from this data will encourage the collection of better data. And I am pleased to see that you actually went in to see, if the data has improved at all in terms of air quality monitoring. So I just wanted to highlight the importance of the data that you've collected and what our MPH students are doing. So again, well done and thanks.
Thank you, Prof. Thank you very much. Thank you.
Thank you. Tshepo, I've taken the liberty of putting your email address in the chat. Monica asked for it. I hope that's okay. And Mohammed, I see, has given us a link to a systematic review on pollen exposures and asthma exacerbations that we just published. I just have one comment to make, and I was wondering whether, and then I know it's obviously would have enlarged the study somewhat, but whether a fair percentage of children with perhaps milder asthma presentation don't end up at the district hospitals from those areas in the same time. So you could be missing potentially a sort of large proportion of affected children. My sense would be it's the sicker kids that would end up at the Red Cross Hospital. So it's just a comment, really.
And you're right, Prof is there.
Akil has got the question, and then I think that's the last question. Akil, do you want to ask your question?
Yeah, I just quickly want to comment on Tshepo. Congratulations on good work, and share the the challenges that you had, especially with the air pollution data, and which is very difficult in the Western Cape. Well, in South Africa, especially with load shedding, is even worse. So I share that. But well done on doing the project, and also other ways of that we've collaborated with other groups in trying to get air pollution modeling is to do air pollution modeling or other ways of imputing air pollution concentrations in South Africa. That's another way that one could look at association between particular air pollutants but otherwise, well done on an interesting study.
Thank you, Prof. Thank you.
Okay, thank you. I think we've reached the end of the meeting. Thank you very much, Tshepo, for agreeing to participate. I think we all found it really, really interesting. And yeah, if there's no more questions, I think we're going to end of there. Thanks.
Thank you, Prof.